Our first speaker has been selected as one of the 100 most influential women in oncology in Onco Daily this year. It's my pleasure to introduce Dr. Samantha Siegel, or Dr. Sam as she calls herself, as the Director of Survivorship Medicine at Kaiser Permanente, San Francisco. She has founded the field of survivorship medicine for our integrated healthcare system and will be your new host for AIM Melanoma's Beyond the Clinic podcast series. Thank you, Sam, for coming today and sharing your thoughts on the language of cancer.
Thank you so much for having me. I am really excited to share about this topic. So without further ado, I love this quote: "The limits of my language means the limits of my world." So why am I here to talk to you about the importance of language today? Why is language important overall? It's communication, it's how we interact with one another, and it's identity formation. I'm not here to say that there's a right way or a wrong way to use language. Not here to shame anybody. I'm here to offer choices where perhaps there didn't seem like there were any before. I don't know if any of you are Brené Brown fans like I am, but in her book, The Atlas of the Heart, she talks about the importance of language, and the more emotional language that we have to describe our experiences, the more we're able to help ourselves. And I love this quote as well. This is a very popular quote in the addiction recovery community, but it was, I think, attributed to this Dr. Dan Siegel, no relation to me. But if you can name it, you can tame it. If you have the words to describe your experience, the better you can get help for yourself and describe what you're going through. So today I want to talk about the language of cancer as it pertains to kind of three different areas. One is the language of cancer process overall. The second one is the language of cancer and personal narrative and experiences. And lastly, the language and current landscape of survivorship medicine. So cancer process. Anybody feel that immediately after they developed a new symptom or were diagnosed that they suddenly entered into a parallel reality, a very confusing one where people are suddenly using an entirely different vocabulary that you've never heard before, and there's a lot of trauma going on, and it feels like there's a lack of transparency? That definitely was the case for me when I first got diagnosed. And I think almost every single day in my office, I hear people talking about these concepts and how difficult it is to try and understand what is happening when they've just received very difficult news. And there are a lot of important parts in the beginning of the cancer process. So the confusion in cancer, again, it feels like there's this whole new language. Suddenly, as soon as people are diagnosed or they're going through the diagnostic process, people are throwing out words like staging and biomarkers, prognosis, Breslow's depth, Gleason scores, depending on the type of cancer that people have. And other times people even throw out terms like, I'm another member on the team. And while people are really well intended when they refer to this team, I hear all the time that many patients and their care partners have no idea who this so-called team is. And if there is a team, they feel like they're the ones quarterbacking between all the various members on the team. And then there's the trauma in cancer. People often arrive at the start line of treatment carrying so many things. One of the first questions that I ask people when they come to my office in my Onco primary clinic, which is a primary care practice that is focused on people that have active cancer, suspected cancer, or history of cancer, is I ask them, do you have anything that you want to share with me about your diagnostic process or about any family members that have been previously diagnosed with cancer? I think it's really important to share that. And I try to allow a space for that sometimes even before people have received that pathology report that confirms that they have cancer. And the reason is that for many people, they were going through diagnostic runaround for months. People had symptoms for a long time and maybe couldn't really tell what was going on, or they had a symptom and they couldn't get an appointment for months, or they went to the emergency room with a symptom, had a scan, and then received some really hard and sometimes inaccurate news. And then we're just kind of playing catch up. So before people even arrive at the start line of that first visit with oncology, they're carrying all of this. And there can be a lack of trust in the medical system, a lack of trust in themselves, and there's nowhere to unpack it. And I believe that this all contributes to sort of a reduced ability to hear the new information that's going on, to absorb the new language, and to be really engaged in the process of one's cancer. So even if that's not offered to you as an option, I think it's really important, if you start with somebody new and you get the feeling that you can trust them, to say, hey, can I tell you about my diagnostic process? A lot of things went down, and I'd like to share all of this with you, because I need to just get it out so that we can start with a clean slate and move forward. And then there's this kind of transparency issue, and I think it's really unintentional in most cases. Right now, the status quo is that for a lot of people, when they're going through the diagnostic and the staging process, also depending on, it varies from cancer to cancer, but there are many different pieces of information that we need before the oncologist, the medical oncologist, the surgical oncologist can make a decision about the treatment plan, can counsel about prognosis. And these things might include scans, molecular testing, biomarkers, MRI of the brain. There's all these different pieces of information that need to be collected before that start line in oncology can give really good information about, hey, here's the path forward. So the status quo right now is that most patients are just left in waiting with no kind of information. They're just sort of getting all these tests, feeling really terrified about what's happening. And there's not a lot of conversation that's happening with them. And I think there's a lot of different reasons behind this. Sometimes it might be that the person who is doing the information gathering of all these various tests and scans might not be the one who feels really medically qualified to have that conversation about what it all means and what it entails. And so my thought as I was dreaming up our Onco Primary Clinic pilot program that we started was that, well, I think there is something to tell people. Why don't we just tell them that? Like, these are all the different pieces of information that we need in order to help your oncologist at that first appointment have that really rich and productive conversation that's going to give you the answers that you really want as a human going through this process. Like, am I going to be able to take care of my kids going through cancer? What are the next 6 months or a year of my life going to look like? Am I going to be able to continue doing the things that I love? I also think that there are a lot of other things that we can do in this period, like assessing somebody's metabolic and cardiovascular health, checking their other medical conditions and going over their medication list and getting rid of things that they haven't refilled for 10 years, but might be unsafe to combine with other things. Checking people's vaccination status, assessing people's employment status or their financial well-being, and if they might be at risk for severe financial toxicity going forward, assessing social and emotional well-being and psychiatric history, knowing that in many different medication regimens that we give in cancer care, including melanoma, there are often high doses of steroids or medications that can impact brain and neurological function. And so knowing if somebody has had issues in the past can be really important. And you can do all those things while you're waiting and make that process available and transparent for patients. And the other piece of transparency I think that's really important to touch on nowadays is that sometimes the pendulum has swung way too far the other direction and there's too much transparency. There are so many instances where I, as a patient, or even my own patients, have experienced getting their own results, their own scans, like right away, lightning speed. You get a scan, you get the result like within an hour and it pops up and you can't not look at it once it's there, but you don't have any kind of therapeutic conversation with the person that ordered that scan, sometimes for days, weeks, and in some cases, even months. And again, that could be due to a lot of different things. There are these new kind of medical transparency laws that require this information to be released automatically. And I do think that that's a good thing, but there's this time coordination aspect where your very well-meaning primary doctor or oncologist might, be in the office, super busy going room to room and just hasn't had a chance to get back to their office and see that scan pop up and be able to sit and call you and kind of debrief about what it all means. They might be on call in the hospital and not even looking at that information that's coming in the in basket. They might be on vacation when that result comes back. And it can be devastating. I'll never forget, receiving the results of my PET scan that confirmed my lymphoma had relapsed. And I got that news from the computer without a conversation with my oncologist. And I knew that there would be a plan, but I really had this thought, like, I can see how somebody might receive this information and do something really drastic, feeling, quite hopeless. So there's some real issues with transparency and the kind of sequencing of early diagnostic processes in cancer. So I love this quote by Michael Douglas: "Cancer did not bring me to my knees, it brought me to my feet." Next, I want to move on to the language, from the language of process to the language of experience and personal narrative in cancer. There are so many really important words that I learned being deeply involved in the survivorship community, being aware of concepts like battle language, scanxiety and fear of cancer recurrence, or FCR, body betrayal, reestablishing body trust, grief, humor, healing being separate from curing, and even the word metaviver. So I just want to touch on battle language. There's this really interesting story that happened recently. I was on a call. I work for Kaiser Permanente, and I was on this national call for our cancer line with hundreds of different clinicians on the call. And at the very end of the call, somebody put something in the Teams chat advertising about an event that we had coming up called Fighting Cancer with Kaiser. And I put in the comments what I thought was a pretty innocuous comment, like, "Hey guys, any chance that in the future we might rebrand this event and call it Facing Cancer with Kaiser?" Battle language is a narrative that doesn't resonate with everybody, and some people just find it, that it's really imposed on them by society, and that, something like facing cancer implies more of a partnership instead of this win-loss and battle language. And to my shock, somebody thumbs down the comment, and I didn't look and see who it was, but I shame spiraled for about 5 minutes. And then after I recovered from that, I was trying to think so deeply about, like, what's that about? And why did somebody thumbs down that comment? And I think my heart settled on the fact that cancer is extremely emotional. It's emotional for patients, for care partners, and I think it's emotional even for the clinicians who take care of the patients. And when it comes to battle language, even in one human experience, one person's cancer experience, I think there are times where it absolutely feels like a battle. I know that during my transplant, it really felt like a nuke bomb was going off inside of me with the chemicals and everything. But then there were other parts of that same experience where the battle language absolutely didn't resonate. And it felt like I wanted to focus on self-love and healing my body. And there's a lot of people that feel that way. That the win-loss language doesn't resonate. And especially people who are diagnosed with late stage where, what they're hoping for their outcome is life prolongation and living a really long time, but they may never achieve an end of active treatment or go into complete remission. And how does battle language make them feel? And I'll never forget a story from one of my close friends who passed from leukemia in her 20s. And she had her fiance read at her memorial service. He read a quote from her that said, "After I'm gone, please don't say that I lost my battle. They gave me 6 weeks when I was diagnosed, and I danced for 2.5 years." And that really stuck with me. So the reason that I bring up battle language is not to say that it's right or wrong, but just to make people aware that there's a choice there. And if that narrative doesn't resonate with you, then just say that. You don't have to take that on. So the next narrative is about scanxiety. And oh my gosh, this one also really resonates with me and with a lot of people. Scanxiety is this feeling like the next scan that's coming up might determine your foreseeable future, or the feeling that you're living in between scans, or just this intense anticipation leading up to your scan with kind of fear or ruminative thoughts, making it difficult to sort of engage in life. It's a thing. Someone told me that there might have even been an article in the New York Times this past week about scanxiety. So I think there's growing awareness about the emotional experience of what it's like to be living between scans. And then there's also this concept of body betrayal and reestablishing body trust. Many people describe to me the feeling of having to forgive themselves for maybe not recognizing the sign of cancer or the symptoms. I know that this is something that I can relate with on a personal level. It took couple of months before I realized that being so tired and falling asleep at 8 o'clock and having a cough that I was attributing to the wildfires ended up being cancer. And I felt it took a while to forgive myself for not realizing that something really serious was going on with my body. And a lot of my patients can relate with this feeling of body betrayal. And how could this have been happening in my body when I was a vegetarian marathon runner, or I used sun protection all the time. How could I have developed melanoma? People feeling so betrayed by their body. And then some people feel that they have to forgive they have to forgive themselves because they actually did seek help. They went to a medical appointment and they were reassured, maybe without a test, about the symptoms that they were having, or they had an initial test that turned out okay. It didn't show anything, but their intuition was telling them that something was really wrong. And they just sort of accepted that first test and didn't press on. And people really harbor sometimes some self-guilt about that and have to work on the forgiveness aspect of it. So, and then another important aspect is kind of learning how to be in your body again, learning how to physically inhabit your body after being diagnosed with cancer. A lot of what people describe to me in the fear of cancer recurrence kind of experience is that it's really hard to sort of learn how to be tuned in enough that you're sort of being aware of new symptoms that are coming up and bring those symptoms to your medical team's attention. Could it be something? Could it be a recurrence? Could it be a complication from treatment? So being tuned in enough to listen to your body and new symptoms, but not being so tuned in that every single bodily sensation kind of sends you into an emotional tailspin, being really scared or overly alarmed at, something that might not be dangerous. So that's a process and it needs attention and a narrative. And then we probably have a lot of metavivors on this call, people who may not even be aware of the term metavivor. A metavivor is a person living with active metastatic disease. And metavivors are becoming increasingly common with the advent of targeted therapy and immunotherapy, all the different therapeutic options that are allowing people to live active and full lives with late stage cancer. And I think metavivors have shown us a very important aspect in the cancer survivorship space, that healing and thriving are not necessarily synonymous with curing. I have quite a few patients now that are living extremely full lives. They're working, they're playing guitar, they're painting, they're jogging, they're doing many different things in their lives, and they're not cured. And they're living with cancer as a chronic condition. And this population of patients, many of them, my friends, have shown me that it's really important to consider my metavivors in the survivorship space. So surveillance is not survivorship. I'm going to say that again because that is really important. Surveillance is not survivorship. And what does that mean? That means that surveillance, which is how we monitor people for a recurrence of their cancer or a progression, or for complications of treatment, that is not synonymous with all that is survivorship. It's an important pillar of survivorship, but it's not the whole deal. The National Cancer Institute defines survivorship as anybody living after a cancer diagnosis through the balance of life. So in the old model, kind of the old way of thinking is that survivorship would start at the end of active treatment. And so when somebody was done with treatment and they were declared to be in remission, and it was heavily geared toward surveillance. And I think that's the history of why those terms began to be used interchangeably. But in that model, there's no place for metavivers. And so what happens in those cases that often the oncologist becomes the primary care clinician for the patient. And that's a lot of weight to be carrying. And metavivers need a whole team. And also, survivorship includes surveillance, but it includes all these different other aspects: whole health, metabolic health, vaccinations, occupational health, monitoring for long-term and late effects from ongoing treatments. And if you only start survivorship for a population of patients that have ended active treatment and are declared in remission, you leave out entire swaths of the cancer survivor population. So in the new model, one that I'm really peddling here, and I hope will grow kind of nationally, is that the care delivery starts at the time of diagnosis and is longitudinal along the way. It's focused on whole person health. So I believe that survivorship and oncoprimary medicine survivorship includes supportive care during cancer. And sometimes that's kind of like a palliative care model, but it can live in survivorship. It doesn't necessarily have to be palliative care. Survivorship also includes rehabilitation, so recovering from really intensive treatments, whether that's surgery or radiation, chemotherapy, targeted therapy, immunotherapy, recovering from the cognitive dysfunction and the neurologic changes that happen when people describe what's almost like a traumatic brain injury from the chemicals of that they receive for their cancer treatment. Survivorship is monitoring for long-term and late effects, so cardiovascular monitoring, and many other ways that all these treatments can affect the body 10, 20, 30 years out, even when people have been in remission for a long time, or if they're on ongoing active treatment. Survivorship is supporting individuals, personal definition of vitality. So what does vitality mean to you? What gets you out of bed in the morning? What defines quality of life for you? That is included in survivorship. And we should be doing everything we can to support each person's definition of vitality. Cardiovascular and metabolic health. I know that one of the things that I said about my bone marrow transplant was that Western allopathic medicine saved my life and it wrecked my health. So that's when I really began leaning into integrative oncology and the importance of, all the different modalities, alternative and complementary medicines, or integrative medicine to support reestablishing vitality and health and well-being and recovering metabolically from high-dose steroids, from, rapid weight gain and liver inflammation or glucose issues that can happen as collateral, impact from the cancer treatment. And that all is really important to improve long-term outcomes. And then relational health, talking to people about their marriage, some people's, relationships, not just marriage, but some people's relationships, whether that's romantic relationships or platonic relationships, communal relationships, are really impacted by the survivorship experience. And they need a narrative, they need help, they need to be connected with community-based organizations like AIM at Melanoma to help them with ongoing learning how to live after a cancer diagnosis. Things like Camp Kesem, which is a free 5-day sleepaway camp for kids whose parents have been impacted by cancer, and occupational health. And so I just want to finish up here with also the narrative of humor in cancer, shattering norms in cancer care. Cancer is really serious and it can be sad. And it can also be really funny at times. I love this quote: "Stuff to do when you have cancer. Use a Nerf ball to see if your oncologist has a sense of humor." One of my close friends, her name is Tati, and she's the one I was talking about who talked about bata language at her memorial service. She had something called an exotic IV pole dancer. When she was in the hospital for prolonged periods of time, she would decorate these really elaborate cardboard cutouts and mount them on her IV pole as if they were dancing on her IV pole. And she liked to use this as a barometer for the personality of of care team members who came into her room, and how they reacted to that was going to determine whether or not it was going to be somebody that she would get along with. And she also liked to wear radioactive pasties on her chest when she would go in for radiation oncology treatments, so that when the staff would open up her shirt to access her port, they would see the radioactivity label, and she liked to get a good laugh out of that. And that was in the last months of her life, and she incredibly found a way to infuse humor in the experience, and to be in touch with her vitality. So there's also this narrative that cancer can be an opportunity to re-examine one's life, that there can be these unexpected discoveries in cancer that are sometimes positive. And we need to allow people to express that. And also activism as medicine, connecting people with peer support groups, raising awareness in the community, are all ways that we can help people in cancer survivorship. So I thought these were also really funny. Because it's October, you have the choice of regular colonoscopy or pumpkin spice, or this one. We did a biopsy and the mole we removed, and it turns out it was just an old piece of chocolate. Warning, chemo farts are toxic. So it's been an absolute pleasure today. Take home points. You decide what language feels right for you. Take notes, engage in your process. You are the most invested in you. Be explicit about who is on your team and what's happening at each step. And you can define your own survivorship and help create the culture of survivorship medicine. Thank you so much.
Thank you, Dr. Sam. Some really good questions coming in which we will cover in the Q&A. Thank you again.